So we're going to do the CPR review for week 13, Lindsey and I. As you're familiar with, Lindsey runs Dog Bomb DES, I run Scrub, so you can find all the information there. Also, there's some question sets I put in the additional resources along with some stuff from first aid that I found helpful. So if you're looking for some extra questions, feel free to go there. Now, we're going to start with cardiac output. And a lot of this is conceptual. One of the things, if you've attended my PLGs, I always talk about the idea, I like to think of the heart as two separate systems, the left heart and the right heart. They're two separate pumps that work together for the end goal, to pump blood through the body. So the left heart, its whole goal is to get blood to the systemic circulation, where the right heart is that reserve volume. It's going to have these pools of blood and it's going to get it back to the heart, however it has to have enough blood in the heart to continue to pump. So I like to think of them as two separate systems. And if you think of it like that, that will help you when you start doing these cross plots. For example, cardiac output is going to be a factor that deals with the left heart. How much can you pump blood and get oxygen to the systemic circulation? Venous return is obviously going to be a component of the right heart. It's going to have pools of blood, and as the heart needs it, it's going to shrink these pools down, and it's going to allow blood to get back to the heart as needed. So I put some equations. I'm not positive it's every equation you need, but I would definitely commit these to memory for the exam.
The big thing about those equations, guys, is knowing what factors are going to cause change for what. So a lot of your questions are going to be based off of this happens in the patient, what changes do you expect to see? And so knowing the equations is going to be very helpful with just conceptualization of what happens when you change this factor, or what happens when you change this factor.
Yeah, exactly. Okay, so let's talk about the right heart. So the right heart is concerned with venous return. How much blood do I need to get from the venous system back to the heart? So by doing this, an increase in blood volume, hypervolemia, is going to increase your venous return. Obviously, the more blood you have in your body, the more blood's going to get back to the heart. Straightforward. Now, venomotor tone is venoconstriction. Don't get this confused with vasoconstriction. Venoconstriction is concerned with the right side, okay, with the veins. So obviously, if you're shrinking these pools down, if you're shrinking the size of the vessels, you're venoconstricting, which also means decreasing compliance. Compliance is how much you're holding. How compliant are you to the fluid? So if you shrink these pools down, you're decreasing compliance. If you decrease the size of these pools, inevitably, you're increasing the venous return to the heart, right? Now, conversely, if you look at arteriolar tone, now this is on the left side of the heart. So if you think about it, if you shrink down the vessels on the left side, you're preventing flow on that side. So what happens is you're not getting blood, the same amount of blood to the right side of the heart, right? So if you have arteriolar vasoconstriction, you're going to decrease venous return. You're basically not allowing a lot of blood to get through, or you're allowing less blood to get through the left heart or the left side system to get to the right side. So these three components, let's just do this real quick. So this is our first line that we're going to be concerned with, this venous return, or this vascular function curve. So when we lay it out like this in equilibrium or homeostasis, your right atrial pressure should be around +2. If it's 0, the veins are going to collapse. But if your right atrial pressure is +2, you're basically in equilibrium. This is where you want to be. Okay, so let's talk about our first factor, okay, blood volume. We said that that is a component of the vascular function curve. That is a component of venous return. And you might say, well, blood volume, it has to do with the left heart too. But you have to remember that most of the blood in the body is on the right side. So that's why this is more important on the right side of the heart. These pools actually collect the blood. So most of the blood in the body is on the right side, just kind of in reserve. So if you increase blood volume, we are going to affect the venous return. Like we said earlier, the more blood you have in the body, the more blood's going to get back to the right atrium. And decrease or hypovolemia or hemorrhagic shock, anything that makes you decrease blood, you're going to decrease venous return or decrease the blood going back to the heart. So this is our first component for the vascular function curve. Now, as we said for venomotor tone, if we venoconstrict or shrink these pools down or decrease compliance, you're decreasing the amount of reserve you have. So therefore, shrinking them down is going to increase venous return to the heart, right? You're just squeezing down on the veins, pushing blood back to the heart. Whereas venodilation, you're just kind of making the pools bigger. You're increasing compliance, so the venous return is going to go down. So that's our second component to the vascular function curve. Arteriolar vasodilation, as we said, if we constrict the blood vessels on the left heart, you're going to decrease venous return. And as you see here, if you vasodilate or arteriolar vasodilation, you're inevitably decreasing total peripheral resistance, right? Because you're vasodilating. So there's not as much resistance. The vessels are larger. So therefore, you're going to increase venous return in this regard, right? The arteries are bigger. There's less resistance. More blood is going through. As I just stated, if you vasoconstrict on the left side, you're decreasing the amount of blood that's going to go circling through to the right side. So that's going to decrease your venous return. And I'm harping on this because this is important when you look at the Guyton cross plots. So as we said, these three components are going to be part of this vascular function curve. They are going to be involved with the venous return to the heart. So now we want to look at the cardiac performance curve. Now this is going to be the left side of the heart, okay? So here we have the right side of the heart, the vascular function curve, and now we're going to deal with the left side of the heart, or the cardiac performance curve. So the main factor here is contractility. How much blood are you able to get out of the left heart to get to systemic circulation? Now, as with medicine, nothing straightforward. We want to remember that arteriolar tone is a component of this. So it does actually affect both curves, arteriolar tone, but that's a factor of the contractility, but we'll see this in a second. So just remember, the main factor you think about here is this contractility for your cardiac performance curve, or the left side of the heart. And we see that here. We looked at this previously. So if you're increasing or decreasing contractility, you're not affecting preload. You have the same amount of blood in the left ventricle when you contract. You're just squeezing the heart harder. If you squeeze the heart harder, you're going to increase stroke volume, right? You're going to increase the cardiac output just because you're squeezing the heart harder. Afterload works the opposite way, right? So even if you're squeezing the heart harder, the pressure or the total peripheral resistance you have to push against is going to affect how much blood actually comes out of the heart, right? So it has the same thing, like I said, as total peripheral resistance. The increased pressure you have to push against is going to affect how much blood comes out of the heart, right? So this has a lot to do with vasoconstriction or vasodilation. If the vessels are vasoconstricted, your afterload is going to go up. You have to press against harder. You know, the pressure is harder to get blood through. Decrease afterload, you're vasodilating. So the blood going through is going to go through easier. So inevitably, you're going to increase your stroke volume. Okay, so these are kind of components, this contractility. You want to remember this, obviously increase preload, increase in diastolic volume, going to increase your stroke volume. We said increase afterload, or that pressure you're pushing against is going to decrease your stroke volume. And we know the harder you contract, the more stroke volume you're going to have. Okay, so now what Dr. Guyton did was he overlaid these, right? So it kind of works out in our benefit here. I'm not positive they did this on purpose, but remember the cardiac performance curve is the left side of the heart. So we classically have this red line or oxygenated blood over here. So if that helps you remember it that way. And the vascular function curve, or the venous return, deoxygenated blood, they usually show that with a blue line, right? So what's going to happen is we're going to overlay these, and these cross plots took me a while to wrap my head around but I think once I got it, it just kind of clicked, right? So the whole point of this is that if the left side of the heart has a problem, the right-sided heart can compensate for it. And that's what these Guyton cross plots show you. And vice versa, if there's a problem with the right side of the heart, the left side can compensate. So the two examples they like to use are cardiac failures, one. So if we have cardiac failure, your cardiac output's going to go down. So your left-sided curve is going to decrease. Well, what do? You have to compensate, right? So the only way to compensate if the left heart is failing is to increase venous return. So if you're not pumping, if your heart has an ejection fraction of 50%, then this curve is going to say, well, squeeze down on the venous system, get blood back to the heart, and pump 50% of a higher volume, right? So if this side's failing, this side's going to try to compensate. It's going to put more blood in the heart. So even though you can't contract as hard, at least we're putting more blood there to get to the body. So that's the first example they use. The other example is hemorrhagic shock. So if, like we said, blood volume is a component of the vascular function curve, if we have decreased blood in the body, what do? Well, you have to tell the left side of the heart, look, we have less blood in the body, you have to pump harder, okay? So by doing that, the contractility will go up. So we have less blood, but we need to get it to the body. So the left side of the heart is going to compensate. So we're going to go into more detail with that, but that's kind of the gist of what I got from this. Okay, so if we lay these out in equilibrium, right, they cross at this point. And this point is important because that will represent our steady state. The right atrial pressure should be at around 2 millimeters of mercury, or the pressure is about 2. And when we look at some of the deficiencies here, or let's go through some examples first of how this can work. So if we're increasing contractility, your first question is, what curve does that affect? And we know that contractility is a component of the cardiac performance curve, which is the left heart. So the red line is going to have to change. Obviously, if you increase contractility, you're going to make the curve go this way or increase, right? Because your cardiac output's going to go up. So, but it still lies on the vascular function curve here. Now, you might say, well, you just contract as hard as you can. Like, that's what I want. I want as much blood to the body as possible. But that's not good, right? You want your heart to stay in equilibrium. You don't want it to have to work too hard. You don't want it to work too little. So by increasing contractility here, there's a, you're going to, the muscle, the myocardium is going to hypertrophy. And if the muscle gets bigger, the chamber gets smaller. So you don't want the heart to have to work too hard because there are consequences. And we can see that consequence here. We're changing from equilibrium. The ideal point here is to be 2. So by making the heart work harder, if we plot it on our graph, it's not at 2, right? So there's a compensation, or there's a consequence to having to do this, okay? You want to be right here at equilibrium. So if you have to contract harder for whatever reason, there's a consequence, and over time, that'll show up. So the main thing here is to remember that contractility, if they talk about it, is a component of the cardiac performance curve, okay? The red line. Decreasing contractility is similar. There's a consequence here, right? When we plot it, it's not at 2. Blood volume, first question, what curve is blood volume a component of? Remember, we said it was a component of the vascular function curve. Okay, so if we increase blood volume, okay, so these black lines correlate to the blue line, right? The blue line is our vascular function curve. And if we plot it here, increased blood volume is here when we plot it on the cardiac performance curve, right? Because it stays on the curve. Or if we have decreased blood volume here. And the point here is to notice when we come down, there's a consequence. There's a consequence to having too much blood in the body. There's a consequence to having too little. And you find that on the x-axis, the right atrial pressure. So major point here, blood volume is going to be a component of the vascular function curve. It's going to affect the venous return to the heart. Okay, excuse me. So remember I said arteriolar resistance or constriction or total peripheral resistance, however you want to phrase it, or mean arterial pressure. Those all correlate to afterload, right? That pressure you have to push against. So remember that arteriolar constriction is a component of both curves. And you can see that here. It affects both the cardiac performance curve and the vascular function curve. But what you see with arteriolar constriction is that by affecting both curves, we can still stay at equilibrium, okay? So this is an important point to make, and you'll see it similarly when you work out, when you exercise, because, and we have a slide for it as well. You'll see that during exercise, that sympathetic activity will affect both sides. It will affect arteriolar constriction or dilation, and you'll see that even under exercise, by affecting both curves, you can stay at equilibrium. So just keep in mind that this arteriolar constriction is a little funky. It does affect both curves, but the body does that so that you can stay at equilibrium, okay? Vasoconstriction, or sorry, vasodilation, similarly, right? The point is, by affecting both curves, we can stay at equilibrium. That's the whole goal. Okay, so now we're gonna get into like the test type questions. So your first question you have to ask is, which parameter are we affecting? Are we affecting the cardiac performance curve? Are we affecting the vascular function curve, right? Because the other is gonna have to compensate. So let's look at decompensated heart failure first. So this is what's gonna happen. If we look at this, right? Remember these black lines are equilibrium. This is our original Guyton cross plot. We come to +2, right? Now we have a problem. The heart's in heart failure, right? So what we see is that the cardiac output's gonna go down. Now, so this curve right here changes to this curve. So you're in heart failure, the cardiac output is not adequate. And we can see here, if we go down, that is our consequence, right? The right atrial pressure is going up. So this is decompensated heart failure. But as we know, if the left heart starts to fail, the right heart's gonna try to pick up the slack. And this is the important point we get here. So let's follow these. And what I wanna try to do is try to put these graphs in words so that we can kind of understand what's going on. So the black lines are our original. If you're confused on the test, which one's the original, find our equilibrium point, +2, and you can work up. So we see the black lines cross here, that's equilibrium. Heart goes into heart failure, right? So they're gonna tell you the cardiac output goes down, okay? You're thinking cardiac output or contractility is a component of the left heart, right? The cardiac performance curve. So we can see this line goes down here to point B, and that's decompensated. Why? Because we're still on the same vascular function curve. The vascular function curve hasn't compensated. But what you'll see is when you have decreased blood going to the body, right? You have decreased cardiac output from the left side of the heart. The right side of the heart is going to try to compensate. So if we track this, we're going to increase our venous return to the heart. The left side is not pumping enough blood to the body. It's not able to. So you're going to tell the right heart to send more blood to the heart so that we can inevitably have a higher ejection fraction or have more blood in the left heart to contract. So you're going to see that this point C, is the compensated point. So you can see the left heart goes into failure and the right heart is able to compensate. So by saying cardiac output goes down, I like the example of using the ejection fraction. So you went from an ejection fraction of 60% down to 50%. Well, the right heart's going to put more blood into the heart so that you're pumping 50% of a higher volume, okay? So obviously over time, this consequence is going to take effect because eventually your heart is not going to be able to compensate. But for right now, you can see that we are able to compensate for it with the vascular function curve, but it's at a consequence. So hemorrhage. Now your first question is, during hemorrhage, what curve are we affecting? Well, we're affecting the vascular function curve. We're affecting that venous return. We don't have enough blood. Okay, great. So let's find our equilibrium point, the black lines. It's going to go down to +2. Now we have Yeah, so, okay. So, right, this line right here is going to be decompensated. So point A is decompensated. Why is it decompensated? Because we decreased the venous return. We decreased our vascular function curve, but we're still on the original cardiac performance curve, right? The left side of the heart hasn't compensated. So this graph is saying we have decreased blood in the body. There's a decreased ability for the blood in the right side of the heart to get adequate blood to the heart, right? The right-sided system that has these reserve volume is being affected. We're not able to get that blood to the heart. So the compensatory mechanism is that point B, the heart's going to say, the right heart's going to tell the left heart, okay, you have to pump harder, right? We don't have a lot of blood, enough blood, so you're just going to have to pump harder. So the blood that you do get, you're going to have to eject more of it. So you're going to say, we have an ejection fraction of 50%. I need you to contract to an ejection fraction of 60%, just because we simply don't have enough blood to fill the chambers. So our normal values here, we went into we had a hemorrhage or hemorrhagic shock, and we dropped to this point here. So our vascular function curve decreased. Then we're going to tell the left heart, you need to pump harder. So it's going to come here, right? So we're going to change both curves. Now, again, that's at a consequence. You're making the heart pump harder and you're changing your equilibrium. So over time, this will have effects. Okay. And then, like I said, for exercise, the point is that both curves will change, but that allows you to stay at equilibrium. And this is that sympathetic activity. So you just want to walk through, when you're doing problems, you want to walk through these types of equations. This is from first aid. It's a little busy for me, but if you want to look at it, you can read through it. So the point of those curves is, first you want to say, which of the two curves are we affecting? The right side of the heart or the left side? Then you're going to say, has the other side of the heart compensated yet? And you would, the curves will change accordingly. So find the equilibrium point, that should be at +2. Find where the deficiency is, which curve is deficient, and then see if the other curve has compensated yet. Okay, I hope that was helpful. So yeah, you can ask us questions if you want.
I just have a quick question about adding digoxin, giving digoxin to someone who has cardiac output or failure. And I'm just confused about what would happen to the VR. It was a pre-test question, and I was just confused with their choice.
Well, ideally you wouldn't. So in regards to the curve, ideally the digoxin would, if we look at this curve here, I don't want to say compensate, would correct this cardiac output. Okay, so ideally we wouldn't have to compensate at all with the venous return, because we would fix this cardiac output back to the normal state and we would stay at equilibrium. So remember, contractility is a component of the left heart. So digoxin says, if the left heart is starting to go down or starting to fail, can we pick that pace back up? Yes, right. So hopefully VR wouldn't have to change. You wouldn't have to compensate. You would just correct the original deficiency. You would contract the heart harder to get it back to equilibrium.
I have a question.
Yep.
In regards to the hemorrhage graph, so you were saying the blood volume decreased, and so compensating it will be pumping more blood. So is that the same?
It would be contracting the heart harder, right? On the left side, right?
Okay. So would that also be increasing the contractility as well? Or
absolutely. Yeah, that's what you'd have to do. So if you have decreased blood into the heart, just because you have decreased blood in the body, you have to contract the heart harder, because that chamber is filled with less blood. So the chamber has to contract harder to get the same amount of blood out to the body. Right.
Think about the cardiac output equation. It's stroke volume times heart rate. And so if you have a decrease in the cardiac output because, of the other factors, venous return, you're not getting a lot of blood in, you want to get that cardiac output back up. So the thing you're going to do, because you can't really change stroke volume at this point because your venous return sucks, you're going to increase the heart rate. And so you're going to try, so your contractility heart rate, you're going to try to increase that to increase the overall cardiac output.
Okay.
Yeah. Okay. Do y'all have any more questions, or we'll move on to the action potential? I think at the end of the day, you just have to sit down and do some practice questions with those and just look at it. But you know, that's the general idea of what what's going on.
So I just wanted to ask, with the right arterial pressure, it mostly is changing as a consequence of either the venous return changing or the cardiac output changing. Is that correct?
Right. So one side of the heart's going to have a deficiency. The other side of the heart is going to compensate. But by compensating, the problem that develops is that you're changing the right atrial pressure. You're changing the equilibrium of the body. So that right atrial pressure is just kind of defining the fact that we are out of equilibrium. Something's working too hard, right? Something's not keeping up pace, and another aspect is having to work too hard. So we're out of equilibrium. Yeah. So that the problem is, over time, the heart's not able to compensate. The left side of the heart will continue to fail and continue to drop, and the right side just can't do it anymore. And that's when you see a lot of problems clinically.
Okay, so it's whenever they bring up right arterial pressure as, like, you know, saying, oh, this dropped, we should mostly recognize it's not that drop that's causing something. It's, oh, okay, it dropped, which means either, you know, the venous return has increased or the cardiac output has increased, like those other things. And that's why you have your change in your right arterial pressure.
Yeah, right atrial pressure. But yes, you're exactly right. Yeah, it's not going to change on its own. It's something else that's going on. So like the digoxin is a good example. You're trying to bring that left-sided heart back to equilibrium, so you could stay at back to its normal point, so you could stay at equilibrium, because the medication, you know, ideally you don't want to change that right atrial pressure, because eventually that'll be consequences. So you want the body to stay in equilibrium. Yeah.
Okay, great. It just helps to realize that the right arterial pressure is not like independently changing.
Right, exactly. Yeah, it's a consequence of the body. So just remember, when one side's failing, if they give you a stem and it says you're in hemorrhage, your cardiac output's going down, you needed to define which side of the heart has the problem. Has the other side compensated? That's what you want to ask. And then you can plot it out on the graph. All right, so action potentials. Okay, so the main thing you should get away from this is the two action potentials you want to be able to identify. They could ask you very simply, at what phase does each of the points correlate to? So we know that this initial 0 phase is that depolarization of the cell of sodium. Then you have this initial hyperpolarization, trying to bring it back down to equilibrium, of potassium. The most important point of this is the second point, which is calcium. And what calcium does, this plateau phase, is it allows time, and the heart needs time to be able to fill, needs time to be able to space out these contractions. Because if you remember, the skeletal muscle, sometimes if you have too many action potentials, you can go into tetany, or you can have these contractions of the muscle. You can't have that in the heart. You need a time component here that allows for the heart to fill. And so this plateau phase, this phase 2, is calcium. Then we have more potassium channels opening. That's going to bring it back down to equilibrium. So remember that this classic curve is going to be the ventricular myocyte. This was a little confusing, but if you remember, down refers to an inward current. You would expect everything except potassium to have an inward current, but these potassium currents, excuse me, are going to be an outward current, right? So it says here, this long depolarization is mainly due to calcium. So just remember that phase 2, that plateau phase, is going to help to extend that action potential in the myocyte. So one more step further is by extending it, we're in this absolute refractory period. We cannot have another depolarization during this phase, at this plateau phase. Very important, because you don't want the heart to keep contracting too much. You need time to fill. Oh, and then relative refractory phase just kind of says that even though we're still trying to get down to equilibrium, you could actually have an action potential, but ideally you would want it to wait. Okay, one of the things I do remember from the test, well, first you need to know kind of where from the SA node where that initial electrical activity starts down to Purkinje fibers. One of the things I do remember from the test, they want you to know the speed at which the conduction is. So you have like the electrical conducting system conveys the electricity faster than the myocardium, faster than the nodes. So just make note of that. Okay, and then the other one, you could see this is a different shaped graph. This is from the SA node. So the SA node firing. These funny channels are sodium that comes in. Then there's a little kick here where the T-type calcium channels come in, and then the L-type calciums. Remember, T-type start before L-type. It's going to depolarize the cell. Then potassium's going to hyperpolarize it back down to equilibrium around -65. You should know this. Chronotropy affects heart rate. So you're thinking sympathetics, parasympathetics. Anatropy is going to be affecting contractility. So you should be thinking calcium, right? So here you can see that chronotropy, if we're going to increase the nodal activity or increase sympathetics, we're going to increase our heart rate. Parasympathetics, vagal tone, remember the vagus nerve is a component of the parasympathetic, or part of the vagal nerve is parasympathetic, and it's going to decrease your heart rate. And then anything, like I said, especially digoxin is a good example, anything that's going to affect your calcium levels is going to affect your inotropy, right? How hard the heart can contract. Okay, so quickly, this was a weird DLA. I think the thing you need to get out of it most, because it goes into a little bit of detail that I don't know that was terribly important, is kind of these definitions. So depending on where you are in the body, what is the control? What runs the control? Is it parasympathetic, sympathetics, or is it local control, or the metabolites that are there? So as long as you have a general understanding of what's the control mechanism in each of the areas, you should be fine. There are also a few definitions that might be foreign to you, something like functional sympatholysis. So the idea is that the sympathetic activity does generally controls the blood flow with vasodilation and constriction, but in certain circumstances, the local control of blood flow can override it. So that's this definition here. I would know that it's specific in the skeletal muscle, the heart, and the brain. And then there's some other definitions. This was a good graph. I put a star on it. So if you could kind of just understand what control runs which system, you should be fine. Okay, let's get into EKGs.
Question, what did you say important about the functional sympholysis?
Sure, right. So the idea is that in these systems, the driving factor typically is the sympathetic activity, whether you vasodilate or vasoconstrict, how much blood flow you get to the body. But under certain circumstances, like under stress, these local control mediators, like maybe decreased oxygen, could override the sympathetic activity and say, even though you're under stress and you're vasoconstricting, we really need a lot of blood to the body. So the local could be based on like the local factors, sensing a decrease in oxygen. They can override the sympathetic system and say, no, we need more blood. Okay, so it just means that in certain circumstances, this local control or the actual center, whether it be the skeletal muscle, the heart, or the brain, can override the sympathetic drive to say, we need more blood, basically.
Okay.
And knowing these factors is very important. And yeah, I mentioned this. Okay, so EKGs is tough. I did leave a little bit out because I didn't think it was terribly important. The most important thing is the mean electrical axis. But you know, when they start talking about the vectors on the chest and which way they go, it's not so important to know the individual vectors, but how they are, how they show up on the EKG. So you don't need to like, they're not gonna, I don't think they're gonna give you a picture of a person with, you know, the leads on the chest and ask you like which vector, which way it's gonna go. They're simply gonna give you an EKG. Now understand that those vectors, that when the heart contracts, those vectors that form in between the leads correlates to an EKG and correlates to the graph points on the EKG. So that's the main point. So we're going to focus on the important stuff. So I put this in here from first aid. You should be familiar with this classic curve here. The P wave is going to be your atrial contraction. The QRS complex is going to be the ventricular contraction. The atrial repolarization is kind of hidden in the QRS complex, so don't worry about it. And then obviously the ventricular depolarization, I'm sorry, repolarization is going to be this T wave. So when we think about this, the EKG, this is the classic form we want to look at. Any deviation from this form, and you can kind of, a red flag should go off in your head. So I just kind of zoomed it in so you can kind of see like where everything works out. Okay, so when you start looking at these, it's very cumbersome. You don't know where to look. The key is lead 2. And if you look at lead 2, we have this classic pattern, right? You have this PQRST, PQRST, PQRS, right? And that's what we want to look at. So when you look at these, you can use lead 2 to figure out your heart rate. Remember, the R is the highest peak on the QRS. So you can go from R to R, right, to figure out the heart rate. But we'll do that in a second. I'll show you how I do it. Okay, just some of the nomenclature here. You should know the waves. You should know the segments, which are between the two waves, and then the intervals, just the definitions, because they can use these in the stem of a question. Okay, and this is just a classic PQRST. And Lindsey, I know we had it when I was going through the slides, you know how they had like the timing of the PR interval and all that stuff? Like, I don't think we really needed to know like how much time is in different intervals. They didn't ask us that.
Unless, yeah, they have a few questions like in the moto questions about the specific intervals and leading to pathology, but I don't remember that being stressed so much on the exam.
Actually, okay, that was for us, but apparently people are saying that
that it was stressed in lecture.
Dr. Toledo is okay. So look, if Dr. Toledo's stressing these time intervals, then by all means, you need to know them. They just weren't high yield on our test. No. So yeah, so maybe you need to know, but you do need to know. You most certainly need to know how to calculate the heart rate. But yeah, 100%
calculate the heart rate.
But listen, if he says you need to know the PR the time between the different intervals, then make sure you commit those to memory. So as I said earlier, you get this vector formation with the leads, and it kind of, you know, each lead correlates to a vector, and when you add the vectors up, that gives you the overall direction of the heart contraction. And by doing these different leads, you kind of get a 360 view of how, a 360 definition of how exactly the heart is contracting. And so, yeah, so like I said earlier, not terribly important, but just so we can get to the EKGs, you get this, these two vectors, one from lead 1, one from lead 2. And when you add them together, you get this, this directionality of which way the heart is contracting. The point here I want to make is that you can see in lead 1, you have a positive deflection. In lead 2, you have a positive deflection. And in lead 3, you have an equal deflection, which means that the vector runs perpendicular, okay? You have an equal deflection positively and negatively. So that means the vector has to run perpendicular to the axis, okay? This will come in handy in a second. Here's a little bit more definitions. You can read this in your own time. Okay, so there's a couple of different ways to calculate heart rate. I like it down and dirty. So you just do it. If you remember these numbers, it's really fast to do it this way. So you just count the big boxes: 300, 150, 175, 60, 50. So you find your R peaks, right? And you count the big boxes in between. So 300, 150, 100, 75, 60. So we know the heart rate in between 60 and 75. So say like 68. You don't have to be perfect. You're kind of just trying to determine whether the heart rate, if they're tachycardic or whatnot. So yeah, if you just do it that way, it's super fast. But whatever way works for you is fine. But just commit these 6 numbers to memory and you should be good. Okay, so what happens pathologically, right? So the main thing you're going to hear about is this STEMI, right? ST elevation myocardial infarction. So this is what happens here is it's a transmural infarct, right? It's all the way across the muscle. And if you have that, you're going to get this classic ST elevation. So if your patient comes in and they're having chest pains and it radiates down their left arm and you see one of these, you know classically that's a transmural infarction. It's a STEMI. Now you could get a smaller infarction and you can get a ST depression, this segment depression. But for right now, you should know that this STEMI, right? This ST segment, it's elevated. It should be down. It should be down here, right? But it's all the way up here, and that just kind of defines this transmural infarct. I put a star on this slide. So it's important if they give you in the stem of the question and they say it's V2, V1, V2, right? So if you on your chest, you know, you lay it out like V1, V2 is going to be straight across your chest. So if you have some sort of problem in V1, V2, you're thinking the LAD is in trouble. So if you have V1, V2, V3, V4, V5, V6 kind of comes across. So it's important for you to know what area that correlates with, because they could say you have an ST elevation in V1, V2. So your initial thought would be, well, that's across the front of the chest around the septum. And if we're there, then we probably have an issue with the LAD or the anterior interventricular artery, right? Or if they give you an anterior apical, right? It could be the distal LAD or anterior lateral. Classically, you're going to see this V1, V2 problem because remember the LAD is that widowmaker. That's the bad. You don't want to get a myocardial infarction in this area because it supplies so much of the ventricular system in that septum. But I would just take a look at these and kind of try to lay these out in your head where they lie on the chest. And if you do that, you can correlate it to a vessel. Okay, so like I was saying earlier, the mean electrical axis, ideally you would have scratch paper and you would be able to lay out the lines and draw them out. There are different ways of doing it. The way I do it is just the general way because I like the idea that they could give me any 2 leads in the stem and I could figure it out. I know there's the thumb method and all that. I did put that in here, but you know, it stresses me out if like I'm like worried about the thumb method and they don't give me the correct leads. Like for the thumb method, you need lead 1 and lead 2, I believe. But yeah, so I like generally using 1 and AVF as well. But they technically in the stem, like they may not give you the EKG and let you pick. They may just say lead 1's this, lead AVR is this. So the way I do it allows you to do it with any of the 2 leads. But by all means, if they give you the EKG strip, use whichever ones work for you. So understand that the teachers do know that you don't have scratch paper and the idea of doing this in your head is stressful and difficult. So your whole goal doing this is to determine what quadrant you're in, okay? You're not gonna have to, like if we had scratch paper, I'd say maybe you need to know a good estimation of the exact angle, the degree at which the vector is going. But because you don't have scratch paper, you know, just finding the quadrant will be sufficient. I remember we had a few questions like this and they were pretty straightforward. And by determining the quadrant, you can see if there's right axis or left axis deviation, but we'll talk about that in a second. So when you first start doing these, just take a piece of blank paper and just make sure you can draw all these out. So you start with 1, it's like the x-axis. Then you're going to draw 2, which is 60 degrees away, and 3, which is 60 degrees away from that. And remember, all the positive deflections, the points with the arrow, have a negative side as well. Okay. And then after you do that, you can lay out the limb leads. So if you're looking at the patient, AVR should be on the right side, AVL is on her left side, and the foot is obviously down. And these also have negative deflections as well. This is more of the same. You can kind of see. You just want to make sure you know. And remember, when they're all laid out, they end up being 30 degrees apart. Okay. This is just a down and dirty way to do it. You have 0, negative 30. So these are all the positive deflections we're looking at. So this is the way I do it. Like I said, they can give you any of the leads and you could figure it out. So first thing is you need to look and you need to see what the deflection is, right? So doing this tells you that this is +2 and this is -1. So this deflection is twice as much as this one, right? Because the numbers should correlate. This is a 1 and this is a 2. This one's twice as much. But the easier way to do it is like this. You count the small boxes. Count the small boxes for the positive deflection and subtract the small boxes from the negative deflection. We're going to go through this slowly, so just bear with me. Okay, so if we look here and we have 8 boxes up and 4 boxes down, then we know it's a positive deflection because we went more up than down. So if we take the positive deflection, subtract the negative deflection, we have a +4 deflection looking here. If we look at 0.3, obviously the negative deflection is much more than the positive. So we get a positive deflection of 1 and a negative deflection of 7. So 1 minus 7 is -6. This one is technically equiphasic. I would prefer if they did a +8 and a -8, so it came out to 0, but they list it as equiphasic. So 8 up and 7 down is a +1. But ideally in these situations, you'd get a perpendicular deflection, which means 8 up, 8 down, or whatever, 4 up, 4 down. The point being, it would come up to 0, meaning you had the same amount of positive deflection as negative deflection. Yes, Jeffrey, that's a good point. This isoelectric is perpendicular, and it's going to help if you find a perpendicular one because you can lay it out on the graph very well, very easily. Okay. So let's break this down. Okay, so we've determined by counting the boxes that we had a +4 in lead 2. So we know lead 1 is here, lead 2 is 60 degrees away, right? We have a positive deflection. So don't think about the blue line, just think about the red line right now. We're gonna go 1, 2, 3, 4. Make a little line right there. Okay, then we're gonna say -2 in AVR. This is why I like doing this method because technically they can give you any of the leads. So -2 in AVR. AVR is the right limb. So if you're looking at the patient, it's the right side. So we have a negative deflection. So it has to go to the other side. We'd say about 1, 2. So we make a little mark here. So we have a mark here and a mark here. Then you want to make a perpendicular line from that point all the way across, perpendicular line from this point all the way across. And then you get a crossing point together. So basically you're saying, this is the vector for lead 2, this is the vector for AVR, and the point at which they cross is the sum of the vectors. So that's the actual vector that the electricity of the heart is going. So like I said, if you had scratch paper, they may tell you, they may say, what is the approximation? I say, I don't know, 110 degrees. But because you don't have paper, they're assuming, you have to do this in your head. So the only thing I feel you would need to know about this is knowing that it's in between 90 and 180. So if you can do this in your head and you can lay it out and say that this is a right axis deviation, it's between 90 and 180, then you should be good. Let's just try it one more time. So we had a +4 in lead 2, so we're going to mark it here. We had a -2 in AVR, so we go across here to about 1, say 2 right there, 2 ticks right there. And then we want to find the point at which they cross. So a perpendicular line from this original line here, and a perpendicular line from this line, and it should be about this quadrant. So that's how you would do it that way. Now, if we wanted to, let's say, I want to do this like, hold on, let's see. Draw, okay. So let's say they give you this, and this is where I would just want to point out the quadrants to you. Okay, so let's say lead 1 is a +4, all right? And this is kind of like the thumb method kind of can work like this too. So we're gonna do this and pretend you're doing it in your head. I know I'm doing it on paper, but yeah. Okay, and then they give you a +2 in lead 2. So if you're doing this in your head, you have a positive in lead 1 and a positive in lead 2. You know, you don't even need to draw the lines out. You don't need paper. You know it would come out somewhere right here, right? If you had the perpendicular lines, it would come out somewhere right here. The whole point is you can say it's in this quadrant, right? So it's a normal axis. You're good. Okay, so let's try a different one. Let's say they give you a negative lead 1 and a positive AVF, right? People like the one in AVF. So negative, let's say -2 on lead 1. So we have to go here, 1, 2, all right? And these lines are arbitrary, but as long as you do them the same on each line, you should be fine. And then we say, let's say we have a +6 in AVF, 1, 2, 3, 4, 5, 6. Right here, you don't have to draw anything out. You know when these lines cross, you're somewhere over here in this. So you know you're between this quadrant, which we're going to talk about in a second. This is a right axis deviation. Okay, so the point is, in your head, you should be able to conceptualize what quadrant you're in. Now, somebody did pose a question to me. They said, well, what if they give you +30 and +60? That would be that would stink, but let's just pretend that's the case. So for it to be +60, like let's say where there's a +1 and a positive AVF, you would have to have more AVF than 1. I hope that makes sense. Because if we draw the line down around 60, or I'm close enough, right? That would be 60. So if you think of it in your head and you're like, you can picture the graph in your head. If you have less of 1 and more of AVF, then you'll be around +60. Whereas if you have more of 1, 6, and less of AVF, you'll be closer to +30. Okay, so I don't think they'll make it this difficult for you. I think they'll give you a number, they'll give you +30, they'll give you +120, they'll give you -150, and they'll give you -60, okay? And they'll just ask you what quadrant. But if you're concerned about this positive deflection here, +30 and 60, you can think of it this way. So it was just posed to me as a question, and that's the best I could do for it. So do y'all have any questions, or do y'all want me to go on? How do y'all feel about that? Okay, good.
I'm sorry, I do have a quick question. I'm so sorry. Yeah. So based off the example you used previously, how would you kind of compare how you found the answer to the previous question to this graph?
Are you referring to actually getting the numbers, or laying them out?
Laying them out. Okay,
yeah, let's see. So it was positive. So that's even a difficult one. I don't even think they would give you that because it's kind of close to it was what, +4 here. And then if we found AVR, it was
-2.
-2. Okay, so we're in this quadrant here. Yeah, see, I think this is even difficult for, oh, I'm sorry, it was lead 2 though. right? Hold on, give me a second here.
Yeah. Oh, I'm so sorry. Yeah, it was negative. It was +4 in lead 2, and then -2 in AVR.
Okay. Okay. So, positive. So this is lead 2. Here we go. Sorry, my computer's in the way. 1, 2, 3, 4, and then AVR was -2, right? Yeah, that was it, huh? And then we did something like this, a perpendicular line and a perpendicular line. And it was like something like that. So even doing that in your head is a little convoluted. I would hope they would give it to you straightforward. Like if you had paper, you could do this, but still the whole goal would be to make sure you're in this quadrant here. But again, when, your lines may be a little different than my lines. I doubt they would give you something directly on the line, but that does bring up a good point. If they give you a problem that's equiphasic, right? That the positive and negative are equal. Say this is lead 2, right? So what this actually tells you is directly on lead 2, you have a perpendicular deflection. So it's going to be straight across in lead 2. It's a perpendicular deflection. So you can use that to your benefit as like a checking factor to see if you get it, to see if the other lines match up. So I would hope that they would give you a pretty straightforward equation. So you can just say 1, 2, 3, 4, and then say lead 2 is 1, 2, and then you just kind of know you're in this quadrant.
Hey, Brady, can we talk real quick about negative versus positive on these lines?
Yeah, so
Yeah, that was going to be my other question.
Okay, so this is a little confusing just because I pulled this off of Wikipedia, but just so we can lay it out. But if we go, this one, let's see. This one, let's see. Okay, this one works. So, I mean, we could use this one. So any of the points that have arrowheads on them are going to be positive. So this is a positive deflection. Think about it, you're going to the right arm, positive to the right arm, positive to the left arm, positive to the foot, okay? And then leads 1 start here, this is positive, lead 2 is positive, and lead 3 is positive, okay? So then the opposites correlate to the other side. So if you lay this out, if you lay this out here, I'll see it still has the degrees. This one has the degrees too. Yeah, okay, well, this one works. So the positive points are the arrowheads are the positive points. So when you do the 1, 2, and 3, just start with straight to the right on the x-axis, go 60 degrees to 2. That's the arrowhead. Do another 60 degrees to 3. The opposite point past the center is going to be the negative line. And then when you do the limb leads, wherever the limb is, so the foot, the arrowhead, the right arm in the patient, arrowhead, left arm, arrowhead. Yep. So ideally, they'll give you something straightforward. They'll give you lead 1. They'll give you AVR. They'll say, let's go back to this one. Let's try this. So they'll say, patient comes in, or let's do a full one. Okay. So let's say this is lead 1, and we calculate it's 4 boxes up and 2 down. So we know that's a +2. Let's say this is lead 1. And let's say AVF equals 2 up and 6 down, right? So we calculate this out to be +2 up, -6 down, which equals a -4. So there we go. We have a +2 in lead 1 and a -4 in lead 2. So think about it in your head. +2 in lead 1, we're going straight out to the right, right? We're on this axis. Negative AVF, that one's the one that's going straight up and down, but we're going up, right? Because we have to be on the negative side. So we're on the positive of 1 and the negative of AVF. So right away, you know, in between these, you fall in this quadrant. Hopefully that makes sense.
That makes sense. Thank you.
Okay, cool. It does get a little convoluted because now, for whatever reason, they consider -30 to +90 a normal axis. We'll get into that in a second. But I just wanted to make sure y'all understood that you just want to find the quadrant, right? So count the boxes, find where you are. So that one, we said +2 in 1, and AVF was -4, 3, 4. So the perpendicular lines correlate to around -60, right? So we would consider this a left axis deviation, okay? So when you practice them, maybe try to do them in your head first and then do them on paper to double check yourself. But like I said, the teachers understand. The ones we had on our test were pretty straightforward. Okay, so let's look at the, excuse me, the axis deviations. And this is the whole point. They're going to give you the EKG or give you the numbers for the leads, and they're going to say what's wrong with the patient. So the first thing, you need to put it in a quadrant, find out where it goes, and then that's going to correlate to their disease status. Okay, so, and this is kind of what we were talking about. So let's say they give you lead 1's positive, lead AVF is positive, right? So AVF's positive, 1's positive. You're somewhere in this quadrant. So it's a normal axis. So you know the patient's okay. If you're over here, lead 1 is positive, AVF's negative. That's the one we just did. So here and here. So you know it falls somewhere in here, the crossing line. So you know you have a left axis deviation. So that's all you're really going to be required to do. Here, AVF is positive, lead 1 is negative. So we're going this way. So we're in this quadrant. So we have a right axis deviation. Now, right axis deviation is going to relate to right ventricular hypertrophy. Piece of cake, easy to remember. If you have a right axis problem, you have a right heart problem. Left axis deviation is going to correlate to left ventricular hypertrophy. Left axis deviation, left heart problem. It makes sense that if a patient has hypertension or increased afterload or increased total peripheral resistance, the left heart has to pump harder against it because it's pressing against this high pressure, right? So the left heart is working harder, and since the left heart works harder, the muscle's going to get bigger, and if the muscle gets bigger, the chamber's going to get smaller. So you're going to get this left ventricular hypertrophy. The left heart's working too hard, left axis deviation. This is a good point. Oh, this is that thumb method, right? If they give you the 2 leads and you want to do the thumb thing, that works for you. Hopefully they can give you the lead 2 for this. I think that's the one that works with. But whatever works for you. I wanted to point this out because just remember, anything from -30 to +90 is considered normal axis. So that's that little weird thing about this. -30 to -90 is left axis, and then +90 to +180 is going to be a right axis. I don't know that we had anything with this extreme axis, but you should be able to quantify that. Just remember this little component. All right, so let's look at some strips. These will be straightforward too. People do fellowships in learning EKGs and cardiology. So the idea of us being able to do it, they're going to keep it pretty simple. So let's look at this. So you want to see the classic pattern, the PQRST, PQRST. So what's wrong with this? Do you see the pattern? Yes, PQRST, PQRST. Now, what's going on here? Well, these R waves, this is the easiest point to calculate. They're too frequent. So you have tachycardia, the heart's beating too fast. So if we use our little thing here, let's calculate it. So we go R wave to R wave. So 300, 150, 100. So the heart's between 100 and 150. Anything over 100 is tachycardia. So you can define it like that. So we went 300, 150, 100. It's between 100 and 150. So you know the patient's in tachycardia. It's a normal rhythm, right? But it's at an increased rate. Now, atrial fibrillation, there's no distinguishable P waves. The atria is just kind of like shaking, right? So you can't appreciate a P wave here. What's important about it is how they define atrial fibrillation, and it's called irregularly irregular. So what that means is there's an irregular pattern and also an irregular complex. So the irregular complex is saying that we don't have that classic PQRST, PQRST, right? And a regular pattern means these R to R intervals is not regular, right? Look at this. This is 1R, this is the next one. Look how far away this one is. So the heart is beating erratically. So you have an irregular pattern. The R to R complex is irregular. It's not an irregular beat. And you also have these funky little lines, right? You don't have this classic PQRST. So it's irregular. It has an irregular complex in an irregular pattern. So we have some ventricular problems as well. So you can see here, this is ventricular tachycardia. So what can we say about this? Is this a regular complex? Well, no, of course not. It doesn't have this PQRST. We actually have no P waves that we could see. But is it in a regular rate? Well, yeah. So this is classified as regularly irregular. So you do have a predictable pattern, but the complexes look funny, right? Ventricular fibrillation, this is completely irregular. There's no discernible QRS complex. You can't define anything by this. So this is a huge problem because you have to shock the patient, give them CPR. You need to try to shock them back into a regular rhythm. This is deadly here. But on the test, they'll keep it pretty straightforward. I remember we had a heart block problem. I think it was a Mobitz 1 or Mobitz 2, and so we'll talk about this. So a first degree heart block just means you have an extension in the PR interval. There's an extension or a prolongation in this segment between the P and the QRS complex, but it's standard. It doesn't change. Everyone's going to be the same distance between the P and the QRS. It's just longer. So a Mobitz type 1, also called a Winkenbach. If y'all haven't seen the YouTube video, search Winkenbach med school, and it's really funny. They made a music video about it. It's really funny. Second degree heart block, Mobitz type 1. So what you see here, and this is what they could give you on the test. So you're going to follow it. P, QRS, T, P looks a little bit longer, right? So you're like, oh, that's a problem between the P and the QRS here. And you're like, okay. T, and then you see P and it's even longer, and QRS, T, and then you see P and you say, uh-oh, there's no QRS. So what is this? This is the Mobitz type 1. You have progressive prolongation between the P and the QRS. It gets longer and longer until you get an eventually dropped wave. So that's a type 1, this prolongation until you get a dropped wave. Mobitz type 2 is just it's not predictable. You don't have that prolongation. You just get a PQRS, T, PQRS. So you can see there's a regularity to it. It's PQRST, PQRST, but you see here this PQRST, P, and it's just dropped. So you don't have that prolongation, right? You just get a dropped QRS complex. And then third degree, there's no association. Like the ventricles generate their own pattern, so you would not be able to see any discernible pattern between the P and the QRS. So you won't get the classic PQRST. You'll just see them beating on their own. But I wouldn't stress it too much on the test. The practice problems you'll do doing these will be much more difficult than the test will. They'll make it easy. It'll be like a Mobitz 1, Mobitz 2. You see the progressive lengthening, or you'll just see a dropped wave and you should be good. This was from, if this helps you remember it, it's like a little poem or something that you can remember the different Mobitz, the different problems. Okay, so the bundle branch blocks, the only thing I really remember from this is if it's a right bundle branch block, it looks like bunny ears. If it's a left bundle branch block, it's like a cowboy hat. So you have this widening of the QRS complex. All right, we'll go through some questions quickly. Were the strips mostly from lecture? I don't know for sure, to be honest with you. I just remember they were pretty straightforward.
Yeah, they're straightforward. They don't have to be from lecture, but they're not going to try to trick you with that, honestly. They're going to give you one and it's going to have that characteristic, the dropping or skipping. So you're going to be able to tell.
All right, so let's just run through some questions. We're not going to do them on Socrative, sorry. Let's just do these. So y'all could put them in the chat if you like. Yeah, of course, right? So we're saying we had an increased PT, right? Prothrombin time. And Dr. Mpadya really likes these. She will use the lab values to correlate to a disease. So if we have an increased prothrombin time, we're thinking extrinsic pathway. Extrinsic pathway is factor 7. So you can see that over here. Remember that you could get problems in the common pathway as well that correlate to a PT or APTT. But most importantly, remember that intrinsic correlates to APTT and extrinsic is your prothrombin time, also called your INR. Cool, so try this one. Yeah, awesome. So this is that don't get it confused with post-translational modification. This is post-transcriptional. So the idea here is you originally make this ApoB 100, but in some circumstances, you kind of want you cut it in half. You only need half of it. So it depends where you are in the body. If we look here, in the liver, you use ApoB 100, but in the intestine, you only need half of it, ApoB 48. So this after transcription, this post-transcriptional editing, you can change that codon to a stop codon, right? And then you only use ApoB 48. Yeah, cytidine deaminase, that might be an important buzzword for you to remember that. That's how we formed this stop codon. All right, try this one. Yeah, very good. What disease are we talking about here? Right, Tangier's disease. Anytime you see orange tonsils, you're thinking of Tangier's. So this is LCAT. So you can see here that this Tangier's disease is a deficiency in the ABC transporter, and the substrate is LCAT. That's the problem, but the buzzword is going to be orange tonsils. Tangerine tonsils. Yeah, there you go. All right. What about this one? Yeah, right. Increased tags, right? Fat in the serum, fat in your blood. You don't want that. So, right, that's going to be an increased cardiovascular disease or potentially. So there's some other things that correlate to it, but these are pretty straightforward, right? Okay, an inhibitor of platelet aggregation. Yeah, exactly, right? So these are kind of more straightforward definitions. Here's a summary slide for it. You can remember what does what. Okay. Remember when you're stressed out on a test, sometimes you forget to read the word not. It's been done before, I promise. You're not the only one. So which one is not? Yeah, very good, right? So E, so nitric oxide does have an effect with vascular vasodilation, right? Nitric oxide. Again, this is more definitions, but you think of nitric oxide as a vasodilator, right? In that GMP pathway. Okay. And what does this guy have? Y'all can talk, it doesn't, yeah. Right, G6PD deficiency. So one of the things about G6PD deficiency, it's usually after some sort of infection or some sort of medication, there's stress on the body. And with this stress, you have this decreased glutathione levels, right? And what happens is it causes this hemolysis in the patient. So you can get increased bilirubin or this hemolytic anemia classically. So this is the pathway. I would try to commit this to memory. With this reduced glutathione, it helps with reactive oxygen species and getting rid of you know, the peroxides and stuff like that. Yep. So this is another sort of definition type thing, chronic granulomatous disease. Remember, these granulomas form the initial bacterial infection. You have a neutrophil response. But after that, you get the macrophages. And typically this is like a tuberculosis. I'm not positive y'all talked about this, but in TB, tuberculosis, you form these granulomas and it kind of encapsulates the tuberculosis in the lungs. So this is more of definition, but we did have stuff on this. So chronic granulomatous disease, remember NADPH oxidase is going to help with bacteria and fungal infections, right? Myeloperoxidase using chloride is specific for fungal infections, okay? So definitely make sure you commit that to memory. Again, look, we're talking about administration of drugs. Sulfa drugs are always a problem in patients. Right, exactly. So sulfa drugs are primaquine for malaria. We're thinking G6PD deficiency. So how will this guy present, right? If you're hemolysin blood, you're getting all this bilirubin build up and you're gonna get jaundice of the eyes, acute hemolysis. You can see it here. Yeah, so hemolytic anemia is classic for that. G6PD, remember it's X-linked. You get this hemolysis. They could ask you the descent. That'd probably be just an extra thing they would put in there, but you're getting a decreased glutathione, which is an antioxidant. Heinz bodies, big buzzword for you. Heinz bodies is definitive for G6PD deficiency. So if they talk about that, Heinz bodies in the red blood cells, that's what you want to think about. Okay. What time is it? 1:30. All right. So this is one of those things. It's something you kind of just need to whiteboard out, you know, when you talk about this secondary hemostasis. So we'll try to go through it right now. So when you have some sort of injury, first step is you want to stop the bleeding. You want to get any sort of mediators. You want to prevent stuff from going in the vessel or out of the vessel, particularly blood. So the idea is that you have this initial vascular spasm. After that, you want to form a platelet plug. You want to form the secondary hemostasis or the factors for hemostasis, and then you want to stabilize the clot. So we can see here the initial injury. You want vasoconstriction to stop the blood. And excuse me, endothelin is a major factor in this, right? You're going to release that from the endothelium. Okay, so now we're going to form this platelet plug. With this initial plug, to stop the bleeding and allow the liver to make that coagulation cascade, those factors. So remember, a good point is that if you have liver disease, you can have bleeding problems because of secondary hemostasis. You have trouble forming that clot or those fibrin threads or activating it. So I put this in from first aid, it kind of lays it out. But what I want to point out is the major mediators. So we have in this platelet plug formation, GP1A, GP1B, and von Willebrand factor. Now these are important because there are diseases that associate with each. The major thing you want to know about the platelet plug is that if you get labs for it, you're going to have an increased bleeding time, okay? And that's because you can't form the platelet plug. If you can't form that, then you're going to have excessive bleeding. So the 3 diseases you're going to want to worry about with this are Glanzmann thrombocythemia, which is a GP2B3A deficiency, Bernard-Soyer syndrome, which is a GP1B, and then von Willebrand disease, which is the von Willebrand factor. So remember, they can give you this and they could tell you there's increased bleeding time. There's one other thing, well, we'll get to it in a second, that can cause it. So the major thing you want to see here is the labs, right? If there's a problem with the platelet plug, it's going to cause an increased bleeding time. That's the labs you're going to get. Now we're going to have secondary hemostasis, and this is where it gets a little convoluted. The whole goal is after you make that platelet plug, you want to make these fibrin threads to kind of like to form this clot. Now the extrinsic pathway is the easier one. The main thing you need to know is the mediators that go with it. So factor 3, or tissue factor, but you can know it as factor 3, is going to activate factor 7, okay? And the whole goal of both the extrinsic and intrinsic pathway is to activate factor 10. So factor 7 is going to get activated, and it's going to use calcium and phospholipids, and it's going to activate the common pathway, factor 10. Intrinsic pathway basically has everything else. So calcarin is, I think you should probably memorize that. Yeah, that activates the initial factor 12, and then you're going to activate 11, 9, 8. So just kind of keep those in mind. You don't necessarily need to draw this out. Just remember what factors correlate to which pathway. And again, the whole goal is to activate factor 10. A good thing to remember is this prothrombinase complex. The point of extrinsic and intrinsic and the common pathway is to eventually activate thrombin. Thrombin's a huge player in this whole scenario. So remember this 10 plus 5 plus the phospholipids plus calcium make up this prothrombinase complex, which will eventually activate thrombin. Here it is all laid out for you. This is busy, but I wanted to put it in from first aid just in case you wanted a little bit extra. Now, why is thrombin so important? Well, you can see it's important because so many factors are involved in activating it, right? You have 1, 5, 7, and 13. They're all involved in thrombin, and thrombin is a player in all of them. So this is an important slide. Thrombin comes in at different parts to both make that initial fibrin threads or lay down the fibrin threads, and also a little bit later on with factor 13, which we'll look at. Okay, so once you do that, then you want to start making this soft clot. So thrombin's going to activate fibrinogen to fibrin, and you're going to lay down the fibrin threads. And then after then that's going to make this soft clot. And then, like I said, factor 13 comes in, activated by thrombin, and you're going to end up making this hard clot. So that's the whole goal here. The initial platelet reaction is to kind of have this initial stopping of the blood, stopping of the injury, and then you're going to have this more advanced fibrin clot that's going to form, and then you're going to make it from a soft clot to a hard clot. Now, the main thing you want to remember for all of this is the lab values that are involved. So if you remember that prothrombin time is a test of the extrinsic pathway, and APTT is the intrinsic pathway. So if they can ask you a multitude of questions regarding this, whether it's extrinsic and intrinsic, and they could ask you factors and stuff like that. But as long as you keep the lab test in mind, you should be good. I thought this was a good summary slide that that Dr. Mpaja put in here. It kind of tells you what goes with what. Okay, quickly, hematopoiesis. So you should be able to identify these histologically. These granulocytes are important. And then the lymphoid stem cells. We're not really talking about natural killer cells yet, but B cells and T cells, remember those come from a lymphoid lineage. An important point to know here is that in the embryo, blood is initially formed in the yolk sac. Then the liver starts making blood, and then closer to birth, the bone marrow is going to make our blood cells, which is how it happens typically in adulthood. So the growth factors involved. EPO, erythropoietin, is going to help make erythrocytes, right? Red blood cells. So the thing that happens is if your body senses that you're hypoxic, right? You have decreased oxygen to the body, it's going to stimulate EPO in the kidneys to make more red blood cells. If you have more red blood cells, you can get more blood to the body. Thrombopoietin is going to make platelets, right? Thrombocytes. And then cytokines are going to be involved with white blood cells. The thing I want you to keep in mind is IL-7. That's a good one to remember specifically for cytokines. And super important, I remember this one. At what point, what is the most important point here in the lineage? The myelocyte phase. And this is important because this is the point at which you get specific granules. That's what they could ask you on the test. Where do you get specific granules? And what exactly does that mean? Well, at the point you make specific granules, that's when you could determine the lineage of the granulocyte. Is it a neutrophil? Is it an eosinophil? Is it a basophil? Well, these specific granules correlate separately to each of them. So the myelocyte phase is the important point. You get these specific granules, and it's at this point you could say definitively what cell type this cell is going to end up making. Okay, again, histology is going to be your friend on this one. The histology stuff, the stuff from Gray's, those are going to be the easy questions. The physiology is going to be the harder. So make sure you can nail these down so you get your points. Okay, fibrinolysis. Major thing here is after you make a clot, you got to break it down. So vitamin K is a huge factor here. Factors 2, 7, 9, and 10, or I think it's 1972, that's how some people remember it, are going to be the clotting factors or the coagulation factors. So remember that all of them need calcium, right? And then protein C and S are going to be anticoagulants, but they also need vitamin K. Vitamin K is involved in gamma carboxylation. That's a good buzzword for you to remember. And then the medication you want to remember is warfarin, which directly inhibits vitamin K. So you can't actually recycle vitamin K because of warfarin. That's a medication. It's an anticoagulant that's used in a lot of people. Okay, and the whole point here is that you can activate plasminogen with these different, the plasminogen activator, urokinase, and streptokinase, activate it to plasmin, and then you're going to break up the clot. One of the major things you can test for clinically is these D-dimer formations. So what you have is when this clot actually breaks down, it releases D-dimers. So patients that have a deep vein thrombosis or a big clot, typically in the leg that blocks blood flow to the leg, a lot of time when this clot starts to dissolve, you're going to get an increase in D-dimer levels, right? That's going to be the byproduct of this clot dissolving. And the problem here is if there's a big clot in the leg and it starts dissolving, it could end up shooting up to the lungs and you can get a pulmonary embolism. Okay, that may be a little advanced, but it's important to know that the D-dimers correlate to the breaking down of the clot. Now we'll go through some anticoagulants, some you need to remember. Antithrombin 3, remember heparin is used clinically. It's also an anticoagulant and it's gonna activate antithrombin 3. And as we said, protein C and S are required for gamma carboxylation, or vitamin K and gamma carboxylation is needed for protein C and protein S. And then I put a star on this slide. Remember, aspirin irreversibly inhibits COX-1 and COX-2. Heparin activates antithrombin 3. Warfarin will block the use of vitamin K. And streptokinase is a plasminogen activator, which activates the plasmin, which will help you break down clots. Most importantly, for Dr. Impalia, she's going to give you these lab values. Remember, we said bleeding time correlates to a platelet plug or a problem with platelet plug formation. So your first question, if you have an increased bleeding time, is do we have adequate platelets, or do we have thrombocytopenia or decreased platelets? Because that'll cause it, right? If you have low platelets, you can't really form a platelet plug. And if we do have normal platelets, then it has to be one of these deficiencies that correlates, right? Like Bernard-Soyer syndrome or Glanzmann thrombasthenia. So she'll give you a graph with bleeding time. She'll give you the platelet count, and they'll ask you, what's going on. So we kind of talked about these defects in platelet plugs. Von Willebrand disease obviously will do it, and then these other diseases we just talked about. I wanted to mention hemophilia A and B quickly. They're X-linked recessive, and hemophilia A will be factor 8 and B will be factor 9. So obviously those fall in the intrinsic pathway. So they can correlate to a problem, if they give a prolonged APTT. You can think of anything in the intrinsic pathway, technically the common pathway. It can be hemophilia A or B. And it could also be von Willebrand's disease. Now, von Willebrand factor correlates with factor 8, but remember, if it's von Willebrand's disease, not only will you get a prolonged APTT, but you'll also get a prolonged bleeding time. Okay, Lindsey's gonna take over here. Do you want me to do the slides, or how do you want to do this?
Yeah, you can just do the slides.
Okay.
Okay, so there's a little overlap, but again, anytime there's overlap, you know that it's really high yield. So we're going to start off with a question. Oh, the picture didn't show up on here. So he has a red, and he has exudate on his tonsils. That's what the picture is. There's white spots on those tonsils. Yeah, it's going to be B. So the big thing, you can advance the slide if you want. Yeah. So whenever you see that picture, and that picture is going to be on a slide in a couple of slides, but this is just kind of my intro because I wanted to do a comparison. Whenever you see an exudate, whenever you see something purulent, it's always neutrophils, because neutrophils are going to be that first cell that comes to a bacterial infection. So anytime you see a pus-filled anything, it's always going to be neutrophils. And that is what this acute inflammation is. So the vascular dilation, endothelial activation, this stuff is very similar to when you see the hemostasis. So you get a cut and you have something that happens at that site. So this is very similar to that. But the big thing you need to understand about that are the neutrophils, and you're going to get this exudate. You can go ahead and so this was the picture that I wanted to show you guys, but they characteristically will put something like this on your exam, but just remember it's neutrophils. You might get 1 or 2 questions about something like that. And also make note of the pyogenic bacteria. So Staphylococcus, they could put this on this. This is fair game. I didn't put the slides on here, but I do think we needed to be able to tell the difference between a lobar pneumonia and the different kinds. So make sure you do make note of both of these, but neutrophils is the big one. If you can go back to the comparison slide, Brady, real quick. So chronic, so acute, the big thing is just neutrophils. Chronic, you do want to know the cell types that are there, because if they can give you a slide, or they can give you a they can describe a histological site and say, a bunch of macrophages, a bunch of lymphocytes, and you can say acute versus chronic. So make sure that you do know the cell types of acute versus chronic. Now, they will have a couple questions on non-granulomatous versus granulomatous. Immunologic and non-immunologic, it kind of goes under these two. it's not really as high yield, but there is a slide where I'm going to show you the difference between different cell types that you will need to be able to distinguish against. So you can go. So suppurative versus fibrinous. So this is the difference between the purulent versus the fibrinous. They talk about this with it's just a different location. So they're both exudate, but make sure you know the difference between purulent exudate, which is the neutrophils, is the bacterial infiltration, versus the along the line, you're getting that fibrin. Remember, in the hemostasis and hemolysis, you have that fibrin as kind of the end point where you're building that lattice work. That's what this is. So make sure you can know the difference between the two. So chronic granulomatous inflammation, I put this on here because you need to know the difference between these two cells. And these two cells are going to be characteristic of either a non-immunological agent or an immunological agent. So make sure you do know the difference between these, and you can tell with a slide and or a clinical presentation what they're getting at here. Okay. So we went over this a little bit, but I want to go over it again because you will get a handful of questions over this entire topic. So the pentose phosphate pathway is kind of another pathway out of glycolysis. So cytosol of cells, and it provides NADPH, and mostly for the red blood cells. That's what they like to relate it back to. So make sure you know where it happens and what the big product is. Here you go. So erythrocytes, this is the big one. I just wanted to point this out because the glutathione, that's what Brady was talking about earlier. So you need this, as it goes hand in hand with kind of the reactive oxygen species. You want to make sure that you have the antioxidants in there. Okay. So the uses, again, important for red blood cells. So detoxification of hydrogen peroxide, this goes hand in hand with antioxidants. And then this is what I want to go over next. So the phagocytosis in white blood cells, which correlates directly to the respiratory burst test. You can go to the next one. So neutrophils, this is the primary cell that comes in right after an infection, right after something happens, and they are responsible for this burst, this respiratory or oxidative burst. Okay. You can put this in the chat. We have some D, I think we have one B, we have a C. Okay, you can go. It should do the answer next. Oh, okay, it didn't. So it is C. So it's NADPH oxidase deficiency and negative respiratory test. I put this on here because you need to know the difference between the deficiencies and then the respiratory burst tests. And Brady had this slide up in his section as well. Make sure you know this, because on the exam, they will probably have a question or two about each of these. And one of the things that can help you narrow down is the positive versus negative respiratory burst test. So the myeloperoxidase deficiency is a positive respiratory burst test, and then chronic granulomatous disease correlates with an NADPH oxidase deficiency. And so you have this lack of the oxygen consumption. So it's defective. So make sure you can tell the difference between those two. Okay. We've gone over this, but let's see if you can actively recall it instead of picking it out of a lineup. Yeah, G6PD, you're probably going to have maybe 2, maybe 3 questions on this on the exam. So you can go to the next slide. So I actually put the big high yield stuff on one slide. So you have, it talks a lot about this in the PPP slides, but it also has its own DLA. But basically, it says the same thing. It's X-linked recesses. If it results in hemolysis, Heinz bodies, you know, we talked about that. Most severe in red blood cells. Why is it most severe in red blood cells?
Because it's increasing your oxidants.
Yeah,
And there's
it
no
has,
nuclei.
yeah, it has no nucleus. And so your yeah, no nucleus, can't make their own NADPH. And so you have to have, so red blood cells, the chief way to get energy is going to be your glycolysis. And yeah, so PPP, yeah, so you're not going, you don't have the enzyme and you can't do the HMP pathway. Those are interchangeable, HMP and PPP. And so you're not getting the NADPH and you're not having those reducing factors there. That's the big thing. You don't have the glutathione there. And so you get damage. And so, oh, go back real quick. Sorry, Brady. Okay, and then infections. Fava beans is a huge one that we haven't mentioned yet, but fava beans, they'll probably say they ate some fava beans. And then allelic heterogeneity, they can always throw that in if they talk about a genetic concept with respect to any sort of pathology. Okay. So hypertension and heart failure, we've gone over some of these concepts. I know a bunch of people were wanting to go over this. So biggest thing to keep in mind are the changes. And I mentioned this before at the very beginning, but a very large percentage of your questions will be based off of this. If this changes, what happens? Or given this condition, what can you expect to see in this patient? And this, since these concepts are incorporated throughout all of these different lectures, it means that it's going to increase the number of questions you're going to see about them. So please make a mental note of that. So we'll go through some of these concepts. So first start with the question. AJ is headache. You got a bunch of C's. Yeah, that's correct. So you're going to have that vascular smooth muscle hypertrophy. What that correlates to is what, guys? We have hypertrophy of the vascular smooth muscle. What's going to happen? Increase TPR, exactly. And you're also going to decrease the vascular compliance. So that kind of all goes hand in hand. So next slide. So this is just to point out the equations a lot of times will help you identify those factors that will change. And so make sure that you know them, not just for calculation purposes, but to understand the concept if something is changed. Because if you are narrowing something down and you have it down to maybe 2 answer choices, knowing the equation might actually help you answer that. So that was the point of putting this here, knowing mean arterial pressure. Next slide. Okay, what I want you guys to notice here is the different things that are changing. So I don't think the difference between the different types of hypertension were 222 high yield, but do make note of the types and what's actually changing. So increased cardiac output, increased CPR, increasing retention of sodium and water.
Hey, Lindsey, I have a question.
Go for it.
In the previous slide.
Mm-hmm.
So when it says that normally, no matter how high the cardiac output or total peripheral resistance is, renal excretion has the capacity to return blood pressure to normal by decreasing blood volume. I don't understand what that means, because if that was the case, why do these people still have the hypertension, right?
That's a really good question. And we're going to go a little bit in the subsequent slides, but this is going to make a lot more sense when you get to CPR 2, because it goes into renal very heavily. Some of these concepts, and we're going to go over that, the DLA of blood pressure control or volume control or whatever. Yeah, this takes longer. This is a much longer compensatory pathway, but this is going to be due to blood volume. So this is a compensatory pathway, but remember, and we'll talk about this in subsequent slides, anything that compensates is trying to get yourself back up to equilibrium, but that doesn't always mean it's a good thing, right? Just because we're changing something, the body doesn't want that change. The best case scenario is to go back to normal. It's to go back to that original equilibrium point where you didn't have to compensate. And so we're going to get a little bit, I'm going to talk about this as the slides go on, because I know that renal, this stuff is pretty hard to conceptualize right now because you haven't had those lectures.
Okay, thank you.
Yeah, so we can go to the next. Okay, so this one is talking about different types of hypertension, but again, what I want you guys to what I want you to look at are what kind of happens, what happens along the pathway, and then kind of what is the end result here. So this is the neurogenic or stress. So you have the sympathetic firing a lot, and so you're getting that smooth muscle hypertrophy, vasoconstriction, and increased TPR. So increased bouts of high blood pressure, so just chronic stress over and over again, and then you get that hypertrophy and vasoconstriction. So what I want you to look at this slide is what is changing down the line. So like if this person doesn't compensate, or this person doesn't have, it's untreated, what can happen over time? What are the consequences of this? That's what I want you to look at here. Again, this is that next slide. This concept is big in renal, but I'll go over it really quickly right here. So blood volume relates to salt in your ECF. It's salt and ECF. This is kind of goes hand in hand. You're going to talk a lot about this in renal. So if you have a decreased salt content, you're going to have a low blood volume. So what does your body want to do? And you're going to have a low blood pressure. You want to reverse it, right? So you're actually, the end result is going to be, you're going to increase the plasma volume. So this is what your renal system is trying to do for you. But remember, hypertension, because you're increasing venous return, you're increasing stroke volume, and you're increasing blood pressure as a consequence of increasing the blood volume, you are also going to get vascular smooth muscle hypertrophy, vasoconstriction, and then increased TPR. This baroreceptors, just know that this is not going to be a long-term solution. It's not involved in long-term regulation. So just know that if they're asking you about baroreceptors, this is kind of an immediate sense. It's an immediate change, and it's going to help you just for a couple of days, and then it's not going to do too much after that point. Okay, I started this one because these are all things that are going to be consequences of the uncontrolled hypertension. So you need to know all of this. And I put a circle around this one, put a square around this one, because cardiac failure is one of those big ones of uncontrolled hypertension. And that's what this lecture goes into a lot. Okay, you can put this in the chat. Yes, it is ejection fraction. So cardiac output is stroke volume times heart rate. So it's kind of over a minute. It's the work of the heart, whereas ejection fraction is basically how much blood is getting pumped at each beat. So it's the effectiveness of the heart in getting blood to the rest of the body. So again, good indicator of contractility. So how effective is the heart of getting blood out? Okay. So systolic versus diastolic blood pressure. This kind of makes sense if you think about it. So systolic, you're reducing contractility, you're reducing stroke volume. Frank Starling curve shifts down to the right. I circled this because anytime you can manipulate a graph, they can probably test you on it. So make sure you do understand what happens when you look at those curves. And you're going to have a reduced ejection fraction with systolic. So what is the equation for ejection fraction real quick? Put it in the chat.
Stroke volume over end diastolic.
Exactly, stroke volume over end diastolic. So if we're reducing stroke volume here, we're gonna change a value of the ejection fraction. But look here, diastolic stroke volume is reduced, but you also have a reduction in end diastolic volume. So even though both of these factors are changing, you're not changing ejection fraction because both of these are going down. Whereas systolic heart failure, you're only getting that reduce in stroke volume. And so you are going to have that reduction in ejection fraction. So that's why a lot of questions will say systolic heart failure and talk about ejection fraction in that way. So that's a good way to distinguish between those. Again, pay attention to the factors, what's going on. So the decreased contractility, you're not getting that stroke volume because the contractility, remember, it's the effectiveness of the blood to get the heart out and into systemic circulation. So if you don't have good contractility, you're not going to have that blood getting out of the heart because it's not as effective. So you're reducing the ejection fraction, also afterload. Anything that makes it hard to overcome that pressure and get the blood out of the heart is going to increase the afterload, which means stroke volume is going to be low, EDV is going to be normal, EF is low. So reducing the ejection fraction. And then this is what we were talking about above. You have decreased ejection fraction, but EF is within normal range because stroke volume is low. Both of these values are low.
Quick question. With
yeah.
the heart failure, the heart rate increasing, should we just associate that with the contractility?
Heart rate is going to be a compensatory mechanism because you have decreased cardiac output. And so because you have decreased cardiac output, one way to increase that is to increase the heart rate. So contractility, it's not necessarily like totally congruous. Contractility is just the effectiveness, whereas cardiac output is what your heart is actually putting out. Contractility, does that make sense?
Kind of. So it's kind of that your contractility is dropping, so then your heart will increase its rate to compensate for that, to try to get the cardiac output out then, right?
Both factors are independent, but they're both going to increase your cardiac output. Think of contractility involved with stroke volume, right? Stroke volume times heart rate equal cardiac output. Contractility is going to literally increase your stroke volume, the volume you pump out. But heart rate, it's an independent factor, but by increasing heart rate, you're also going to increase your cardiac output. So whether you contract harder or you increase the heart rate, the whole goal is to put more blood out from the heart.
Okay. So in at least in this, with the conditions that cause like left ventricular failure, the ones that are on this page are really talking about how they impact stroke volume, whereas heart rate is just its own little thing that will be increased.
So,
like
heart rate is going to be the compensatory mechanism.
Okay, there we go. Okay, that makes sense.
Yeah, this can kind of lead to heart failure. These are factors that are getting you there. Heart rate is going to be your body's attempt to correct it. That makes sense.
Yeah, that makes sense. Thank you.
Yeah. So we can go to the next slide. Okay, again, anytime you can manipulate a graph, you need to know what happens. And so these PV loops, you're not just going to see them with respect to the murmurs, you can see them with the heart failures as well. So Again, systolic, you're decreasing ejection fraction, you have impaired contractility. So like Brady said, you're not getting it directly. This is what your stroke volume is. If you have a more effective heart, you're contracting well, you're going to have an increased stroke volume. But if you impair that, you're having an increased end diastolic volume because you don't get that stroke volume out. So in passive wall stretch, so your increase and diastolic volume, compliance, reducing ejection fraction. We've talked about that. Increase in blood volume. This is the RAS system. And I think I have another slide talking about that, but this is the renal compensation. You're holding on to water and sodium to increase that blood volume, because if you increase that blood volume, you're increasing venous return. If you increase venous return, you're going to then increase the stroke volume, increase wall stress and work of heart. Diastolic, remember, it's preserved because you have both decreased stroke volume and the decreased EDV. And so it's going to be at the same ratio. And so you're not going to get a difference in EF. So we're decreasing ventricular compliance with hypertrophy. Remember, this is the big thing with heart failure. So which means you're increasing the pressure, you have reduced filling because of the hypertrophy. If you have an increased bulk there of the ventricle, you can't fill it as well. Normal EF, we talked about that. Reduced stroke volume, we talked about that. So make sure that you can correlate that to your PV loops. Okay, the end points, I really want you guys to pay attention to the pulmonary edema, orthopnea, and then peripheral edema, can't talk. So the pulmonary edema, when the left ventricle fails, you're going to have an increased pulmonary venous pressure, because if your left ventricle is failing, this is what's receiving blood back from the pulmonary system. And so if you're having left heart failure, a very common consequence of that is you're affecting the lungs and the right heart, because you get kind of a backup. And so you have this pulmonary edema. And then so when your right heart starts to fail, think about it. What's down the line? What comes before the right heart? You have the systemic system that's supposed to be bringing blood back up to the right heart. So if the right heart starts to fail, you're getting back up in this peripheral system. That's where you're getting edema. So this is characteristic of more of a left heart problem. This is more characteristic of a right heart problem, because remember, the pulmonary system is going into the left heart system, and the systemic system is going directly into the right heart system. So if there's a defect, then you get back up before that. Okay. So I didn't put the graph on here because I just thought it would get a little tedious, but I did want to point out a couple of things. So the compensatory mechanisms, remember, we're increasing, we want to increase CPR, and we're increasing blood volume. So when you get heart failure, immediate consequence, you're reducing cardiac output. That's what happens when your heart starts to fail. You don't get enough blood out. So what are we going to do? We're going to vasoconstrict. We're going to hold on to our water, because remember, we're trying to increase what we're getting out, and then the sympathetic mediation because of angiotensin too. So I highlighted these because I do want you to pay attention to what are the mediators and what factors we're looking at here. And then down the line, we're going to become less compliant, because remember that hypertrophy, you're not going to have as much compliance. You're not going to be able to comply with change. That's how I think about compliance here. You can move on. So venous return, cardiac output. So just remember your curve. So when you start from normal, what happens initially and what happens, how do you know on each, what each point represents? That's what I'm trying to say. What each point represents, because they can give you a graph like this, they can give you the letters, and they can ask you at what point, what is going on in the body. So continued activation of these compensatory mechanisms isn't good. So even though we're compensating, remember the best case scenario is getting back to what we were before. But if you keep these compensatory mechanisms going and going and going, too much of a good thing can start to be a bad thing. So increasing that blood volume due to water and sodium and water retention, that's the RAS system, that's the renal system, you're going to get that pulmonary edema. Because you're holding on to this volume and it can start to leak out. And then increasing TPR, you're going to increase the afterload, because if you're increasing the resistance, you're not going, it's going to increase the kind of trouble to get the blood out. So if you increase afterload, of course, it's going to decrease stroke volume and cardiac output. Heart rate, metabolic demand, this is the oxygen demand. Sympathetics, you're going to have a down regulation. And if you increase A2 angiotensin 2, can increase the cytokines, fibroblasts, and then you can start the adverse remodeling of the heart. So then it goes into decompensation. Yeah, the next slide. Yeah, hypovolemic shock. So the big thing, nausea and diarrhea, you're losing a lot, vomiting, diarrhea, you're using a lot, losing fluid in your system. And so you are going to be hypovolemic. And so it doesn't only have to be hemorrhage. It can be just losing fluid by pathology. So now I just wanted to go over to your actual slides. I can go through that a little bit. Okay. So just wanted to go through and pick out maybe some high yield stuff. Brady, chime in if you see something we think we should know. So of course, you need to know what happens to the different factors here. This is very testable. Can you all see my screen? Is it showing?
Yeah, we can see it.
Okay, cool.
Okay, sorry.
Very good. So they put a bunch of different types here, but I think for us, like hypovolemic is really big. Septic or anaphylactic is really big, but those are the big high yield ones that I remember. But you might get one question over this kind of stuff right here. Again, what happens with the different values? We talked about this activation of renin-angiotensin system. The big thing you need to know right now in CPR 1 is it just replaces fluid loss. So anytime you see this, you're holding on to sodium water. It's sodium water reabsorption at the level of the nephron in the kidneys. So that's what this is talking about. And you have this in a couple places. This is the hemorrhagic shock. So 24. So whenever it talks about this, they talk about baroreceptor reflex, and then they talk about the RAS system. So just know that you're going to hit this a little harder in CPR too, but this is what they want you to focus on right now. So remember, initial response is the baroreflect response. This doesn't last long because this only lasts for like 1 to 2 days, but that's what that does. Yeah, so RAS is going to be more your long term. Yeah, longer to manifest. So you do have receptors in your kidneys that are going to sense the decrease in blood volume and the sodium content. And so this is going to kick in so you can hold on to sodium and water at this level. I just had a question. How much do we need to know about hydrostatic and oncotic pressures? That gets really big in renal. Yeah, that gets really big in renal. Remind me, did y'all go, this might also be a CPR2 thing. Did you guys go over the capillary stuff with respect to hydrostatic and oncotic pressures?
Yeah, that was our microcirculation lecture, I believe.
Okay, yes, you do need to know that. That is very high yield. That is very high yield. So you will get 2 or 3 questions, and what they're going to do is they're going to give you values, and they're going to ask you which direction is going to, you're going to have lymph flow or fluid flow. But once you get that concept down, the questions become pretty easy, and then you can translate it into CPR2 because the concept is essentially the same. I don't think they went too big into this into CPR1. Do you remember, Brady?
No, that was 2. Yeah, for sure.
They underlined this, but this was more CPR2, honestly. Yeah, if you guys need to head out, you won't hurt our feelings. We're kind of at 2.5 hours at this point. But okay, this is I've had a lot of people reach out to me about this one. It's the DLA on control of blood pressure and volume. This was in our CPR2. Again, I think the biggest thing here, your RAS system is going to hold on to sodium and water. That's the big thing here. You're going to, this is really renal forward, but the baroreceptors kicking in, that's the big thing there. Oh, that was the same one.
So mostly it's like if we have a drop in blood volume, our first responder is our baroreceptor reflex.
Yes.
It's going to try and do its compensatory mechanism to increase our blood volume by vasoconstriction, right?
Mm-hmm.
And then if it's prolonged and it's still not under control, then RAS is like, hey, what's up, kidneys? Like, continue reabsorbing sodium, water follows salt. So then we have more blood volume getting into our systemic circulation, hoping to do that compensatory mechanism to increase our blood pressure.
Yes. The only thing is, it's not like it's not like baroreceptor and then RAS. Your kidneys are going to sense it because they have sensors as well, but it's just going to take longer to kick in is the thing. But as soon as you get that blood volume loss, both the baroreceptors and your kidneys are going to sense that. So the RAS system is going to turn on, but the RAS system involves a lot of systems and involves a lot of pathways and a lot of organs. And so it's going to, yes, reflex and firing are different. It's going to take a little longer to kick in, but both of them are going to kind of sense it at the exact same time once it happens.
What's the difference between the reflex and the firing for the baroreceptor?
Brady, do you have a good answer to that one? The question is the difference between the baroreceptor reflex and baroreceptor firing.
This, but I think they're opposite. Like you would think that like if the baroreceptors sense a change in the pressure, that would cause them to fire. I think they're actually firing normally. And if they get some sort of response, like a drop in blood pressure, they stop firing. Like it's one of those weird backwards things you wouldn't expect, but please double check me on that. They only fire if they stretch. Okay.
Okay, thank you.
Yeah, that's how I understood it too, is like they're constantly monitoring and keeping everything in check. And then when there's an imbalance, then it's like, oh, hey, we have to do something a little bit different.
Backwards from what you would think. Just quickly, there was a question about the embryo material is, that was, what did we do? We did week 11 with the embryo? It was week 11, yeah. It should be on the
first.
Yeah, it's on the YouTube, the YouTube channel on the tube, and on our pages as well.
Yeah, those septal defects are so high yield. Exercise physiology, Brady, what did you remember was there was like one thing we talked about, the Guyton plot, and that is definitely something you're going to see 100% with respect to exercise. I think that's the biggest thing.
We can't remember anything that stands out. Just that sympathetic response does affect both sides, the cardiac performance and the vascular function curve. So it does keep you at equilibrium, even though you're increasing the oxygenation to the body. Nothing really stands out.
Yeah. Does anybody have anything specific they want us to go over that you don't feel like in this session or previous sessions we hit on as hard as you wanted?
Could we
I was
please
gonna
go
ask-
over microcirculation, if you don't mind?
Yeah, let's see. What week was that for you guys?
Let me see.
It was week 12, but it was a DLA 57.
Okay.
You know, honestly, I think BRS had a really good, literally like one-page summary of this if you have access to BRS.
Okay.
Because yeah, this PowerPoint did not help me at all.
I've gone over it like 2 times and I'm still.
Okay, so this stuff might be complicated to get. Once you get it though, it's easy. So if that's any consolation, because it's these pressures that are driving fluid in or out. So the concepts, so first off, you're going to talk about this in renal. I know I've said that like 10 times. The concept of reabsorption versus filtration, you need to know which way that's going. So reabsorption is back into circulation, filtration is out of circulation. So you need to know that. But
they're asking what page in BRS. I don't know what did they refer to. The BRS physiology page, but was this in the BRS phys? Sorry, I was answering question.
I can look, just give me a second.
so I mapped this out really extensively. So like negative value is absorption. But I think conceptually, I just understood this. You need to know this equation. But again, I remember having to do this equation over and over in renal, but you do need to know this equation. So I would memorize this. And when you plug this in, if you get that positive value, filtration, negative value, absorption.
Through it real quick. If you go back up to the equation,
Mm-hmm.
Go back one more, I think has the full thing. Oh, no, it doesn't. Okay, wait, I do want to point this out because sometimes they can give you a KF value. If you look on the from the original equations I put at the very beginning. Sometimes there's a constant here. I'm assuming like they won't give you that on the test. Yeah, it's like this K, this is the actual, it's a K constant. Yeah. I'm assuming since the teacher didn't put it here, they won't put it. But if they give you a KF constant, you have to multiply it by everything. It's in first aid, it's in the original thing. So the idea here is you're trying to determine if we're filtering blood out. So in the capillary, are we pushing blood out of the capillary or are we pulling it back in? So there are two types of pressure. There's a pressure that pushes fluid out, that's hydrostatic, and there's a pressure that pulls it back in. That's called oncotic pressure. And the proteins actually have this pressure. So the proteins have a pulling effect to keep fluid in. That's why when you have liver failure, albumin's a big protein that does it. When you have liver failure, you end up getting really puffy because albumin holds a lot of the fluid in the vessels. And if it can't do that, then all the fluid kind of goes out. Hydrostatic pressure overwhelms the oncotic pressure. So the idea in this equation is, do we have more capillary hydrostatic pressure or more interstitial fluid pressure? So do we have more hydrostatic pressure pushing fluid out of the capillary, or do we have more pressure from the interstitial fluid pushing blood into the capillary? So determining which one is which is going to tell you if you're filtering blood out or absorbing blood back in. Same thing for oncotic pressure. Do we have more pressure pulling blood or fluid back into the capillaries, or do we have more pressure pulling blood fluid into the interstitial fluid? So by joining these together, you can determine whether you're pulling blood fluid back into the capillary or pushing it out. That's the main thing you want to gain from this. And obviously, if you're pushing blood into the fluid into the interstitial fluid out of the capillaries, you tend to swell, right? And if you're swelling, then that'll increase the pressure in the interstitial fluid and hopefully put it back into the vessels and allow you to excrete it.
Yeah, so each side of the equation is going to have one of these. So you're going to have both the oncotic and you're going to have both the push and the pull factor, to put it simply. So your capillary is going to have a push factor, is going to have a pull factor. The interstitium is going to have a push and a pull factor. And so you're basically combining those to see which one has the bigger push versus pull factor. And that's how you're going to know it. But both sides are going to have it.
Yeah, but by all means, like when you do those problems, determining the hydrostatic pressure from the vessels and the interstitial fluid, you need to be able to lay those out, the four components: hydrostatic in the vessel minus hydrostatic in interstitium, oncotic in the vessel, oncotic in the interstitium. So make sure you don't get your values flipped around. Make sure you know which ones are in which component.
So I'm pretty sure if you understand that concept, you understand this entire lecture, this entire DLA, because it just keeps elaborating. Yeah, edema, this is what you're saying. If you aren't getting enough, if you're getting too much filtration, you're getting that edema. Ascites, that might have been a definition, or maybe that was our term. I don't know. It just means abdominal cavity edema.
Is there ever a situation where they can like specifically ask that though? Like, do you have an example of a question for that?
It's in kids that have Kwashiorkor's disease, like in some of the poor populations. There's usually like the kid will show just a really large swelling of the stomach, and it's because of this protein. They don't get enough albumin, and so they typically get these ascites. So they're very emaciated, very small, but they have a really large stomach. These little kids.
Ascites can be associated with cirrhosis as well, because remember, the liver does a lot of those plasma proteins. So if you're not getting the plasma proteins due to liver complications, then you can get that ascites, because remember, the protein is the pooling factor. So if you don't have a lot of that pooling factor in your capillaries, then you could overcome the differential there, and you're going to have more filtration and get that ascites if you have cirrhosis.
That's the one they're going to talk about. Yeah.
Thank you.
Yeah, the biggest thing to know, both sides of the lymph and capillaries, they're both each going to have one of these. Like Brady said, you need to keep them, the 4 values, straight in your head so that you can figure out what way it's going to go. I remember a handful of questions having to differentiate between that or figure out which way it's going to go. But they do like to talk about edema.
Hey guys, sorry. So I understand this equation, or like at least how to plug it in. I just don't understand the moving in or out. Like I understand the filtration and absorption, but Brady, you said something about going out or in. Can you repeat that? Sorry.
It deals with whether the fluid is going out of the vessel into the subcutaneous or the interstitial fluid around it. So we're either going to be pushing fluid out of the vessel or back into the vessel. So each component, the inside the capillary has a push and a pull component, a hydrostatic and an oncotic component that's either going to push fluid out of the vessel or pull fluid back into the vessel. And also the fluid on the outside of the vessel is going to have a push or pull. So there's a constant gradient, whether we're bringing fluid in or pushing fluid out from the vessel, but we're talking about the actual vessel, whether we're pulling or pulling it in.
Got it. Thank you so much.
Anything else you guys want us to run through real quick? Can go back to any of your lectures.
Nothing directly from the lectures, but I was doing a bunch of pretest questions yesterday, and there was one I was wondering if you can try and explain, because it does have to do with peripheral edema, but it also relates back to like a decrease in ejection fraction. So it says like this 72-year-old man was in respiratory distress. He has a ST segment and T wave abnormalities and shows an ejection fraction of 30%. It says over the next several days, significant peripheral edema develops. And then it says the edema is most likely caused by which of the following? And the answer is increased central venous pressure, but I'm having a hard time wrapping my head around like relating, I guess, the hydrostatic and oncotic pressures back to a specific heart, I guess, failure.
So the central venous pressure, it's
right heart. Yeah. So think of it like this. It sounds like this guy has left heart failure because his ejection fraction went down. And what happens then, you get backflow to the pulmonary system, then you get pulmonary hypertension. Then eventually, like his ejection fraction is really low. Eventually you get right heart failure. So left heart failure is going to back up to the lungs. You're going to get pulmonary hypertension. Then the right heart has to push against that pulmonary pressure. So you're going to get right heart hypertrophy and right heart failure. That's when you get peripheral edema. So it sounds like this guy literally has left heart failure backed up to the lungs. Now he has right heart failure. And what's happening is there's backlog into the venous system. So you would expect like jugular venous JVD distension, right? So the central venous pressure is that increased venous pressure. So that's a direct correlate of edema, right? The edema is saying we have backlog in the venous system. So the central venous pressure is kind of like a value for the peripheral edema.
Yeah, and because that pressure can cause leakage. So that's kind of your push factor. If you have that increased pressure, you can have that increased push factor, and that's what's causing that edema right there.
Yeah, because I originally chose a different answer that said decreased arterial pressure because I exactly like you said, Brady, I was thinking left heart failure, but I guess I have to take it a step further and think, okay, if I have left heart failure, what's compensating my right heart? What happened?
When you talk about the failures, think about what comes before it, because it's gonna cause stuff in front of it, and it's gonna also cause stuff behind it. With respect to edema, the arterial system isn't gonna cause edema because that's not where you're getting that. That's not really where you're getting that exchange right there. You're going to get the exchange more at the capillary, like the venous level. And so you're not going to have that push-pull factor at that point.
Thank you. That makes a lot more sense.
Context, like he was 78, right? Or 76. And his ejection fraction was 30. It should be like 60. So he's in severe heart failure. By the time you get down to 30, you know, you're getting back into the right heart. So it's not only is it heart failure, but it's extensive heart failure. And whenever they tell you edema, you have to think, or specifically peripheral edema, you have to think there's a right heart problem at that point.
Yeah, so edema just goes straight to that, like right heart problem, left heart problem, kind of that backlog. So once you kind of train your brain to think that way when you see edema and when you see those symptoms.
Yeah, so anything that causes a backlog, it can cause varicose veins, just that increased pressure. But you also have to have that valvular dysfunction, but this certainly could lead to that in the venous system. And yes, so TPR would be more or less like a total like arterial and venous resistance or hypertension or resistance. But central venous pressure is more or less speaking about the venous side or the right heart side. Yeah.
Yeah, that's the tough thing, is making, like, getting it clear. Like, are you talking about the total systemic system? Or are you talking about the arterial system, the venous system? Because if you change one of those things, it depends on, it can affect what happens down the line. So yeah, make sure to get those terms clear in your head, because that can mess you up a little bit.
Central venous pressure is often, remember in the beginning, we talked about that right atrial pressure and that deviation. Central venous pressure is synonymous with right atrial pressure. So when we were talking about that right atrial pressure changing, you're changing the central venous pressure too when you do that. So that's another thing you can correlate together.
Anything else, guys?
No, thank you both so much. This has been extremely helpful.
You're welcome. We're glad.
Yeah.
Thank you so much.
Don't hesitate to reach out if you come across a question or something this weekend while you guys are studying.
Thank you.
Like you guys go on your own.
We'll post everything later on this afternoon. Y'all want to check it out. So good luck.